Good morning and welcome to the industry session now with Hermes Medical Solutions. I'm very pleased that so many of you have come so early in the morning. Since we are all a little short of breakfast, we have organized a small breakfast for you in the background, so please feel free to take anything you like. My name is Philipp Karsten and I'm the sales director of Hermes Medical Solutions. We are purely focused on nuclear medicine and develop, based on the latest research and developments, innovative software for the evaluation of all nuclear medicine examinations and for planning and evaluation of therapies. Our all-in-one software suite, Hermia, for example, offers precise and innovative possibilities for determining the tumor burden. And with this keyword, I would like to introduce to you Dr. Harun Ilhan. He is a habilitated nuclear medicine physician located in Munich, Germany. He spent all relevant stations of his scientific and medical career at the Department of Nuclear Medicine of the University of Munich, starting with his doctoral thesis and intern time back in 2008, until his time as an assistant medical director. But as all good things, and someday, he joined a private practice for nuclear medicine, radiology, and radiation oncology in 2021, also located in Munich. Nonetheless, he is a visiting lecturer at the Department of Nuclear Medicine at the LMU Munich, where he continues his scientific research and teaching activities. He is also a co-PI of the research training group GRK 2274, Advanced Medical Physics for Image-Guided Cancer Therapy, focusing on Monte Carlo-based dosimetry for radionuclide therapy. In this current lecture, Harun will focus on the impact of efficient quantification of total tumor volume and present data on the value of semi-quantitative PET as a possible predictor of therapy outcome in prostate cancer patients receiving PSMA-targeted alpha therapy. Harun, the microphone is yours.
Thank you very much for attending so early. As Philipp already introduced, it will rather be an example of effective and efficient quantification in PSMA imaging, but not only PSMA imaging. I will also include some relevance of tumor volume delineation and quantification in terms of response assessment, because this is the field of theranostics where a lot of effort has been put in within the last years and months, specifically with a lot of new guideline recommendations as of how to optimize response assessment in patients receiving radioligand therapy. Here we go. So this will be today's agenda. We will focus on the value of PET imaging and tumor volume and on methods of how to do that properly, how to measure, how to quantify the total tumor volume. And I will go to a recent publication of our group focusing on the value of total tumor volume delineation in patients receiving actinium 225-PSMA-I&T therapy. So correlation of imaging and therapy is, of course, one of the basal principles of nuclear medicine and nuclear medicine theranostics. Within this audience, I don't have to go into details here. And here we have a pretty simple example of how that works. You have a patient with PSMA-avid metastatic disease. It's a prostate cancer patient, and he's receiving 2 cycles of radioligand therapy. You can see from the dose that it's a relatively early regimen where we started with 6 gigabecquerel. Currently, we would opt for 7.4 gigabecquerel, of course. But this patient shows very good tumor response after 2 cycles. So it's a pretty simple situation here. What about this situation? And this is courtesy of Wolfgang Fendler, a good friend of mine, and currently in Essen. And here you have a patient where it's not that easy anymore. You have a patient with severe bone metastasis, also from prostate cancer. This patient also received 2 cycles. And on the first look, you might say that this patient, of course, profits from therapy as the tumor volume decreases, and we have areas where the PSMA signal is decreasing. Nonetheless, we also have new PSMA-avid lesions. And considering all of the available or established response assessment criteria, the emergence of new lesions always triggers progressive disease. But this might not be true for PSMA imaging and radioligand therapies in general. And this is something that has been changed just recently. So, is this patient still a responder or not? That's the question that we have to solve. If you have all seen this data also from the NET-1 trial, so the same principle is not only valid for PSMA, but also for neuroendocrine tumors. And I don't have to go into details of the NET-1 trial here. We all know that the progression-free survival was significantly improved. But if we have a closer look on NET patients, we see that there is hardly any gap between patients that show stable disease on imaging and patients that respond to therapy. And we have to go into details of this specific group to determine whether a patient is profiting from therapy or not, because mere morphological criteria will not be the solution to response assessment in radioligand therapies. Here we have data from our group in Munich, from Alex Haug when he was still in Munich. And this is a patient having received PRRT, neuroendocrine tumor patient. And you can see that the mere follow-up based on SUV max values does show sort of a difference in survival rates, but it gets more important if you incorporate a tumor to spleen ratio, for instance. So semi-quantitative parameters are more and more important, and this is not only for neuroendocrine tumors, but of course for prostate cancer. So let me summarize some of the data that is available and still used in most recent guidelines despite being older than 10 years. So this is data showing for neuroendocrine tumors whether there is value of delta SUV measurement or not. And in this publication, they say it's not, which still was used in the 2010 E&M guidelines as a reference that delta SUV can be used despite clearly predicting that it's not of any value. Of course, Professor Baum's group focused on prostate cancer, PSMA, and where they used the delta SUV max values for response assessment, which worked in that scenario. And of course, you can also think about incorporating FDG PET, not only for neuroendocrine tumors, but also for prostate cancer patients as a possible determination or distinguishment between patients responding to therapy or not. And also, as I said, the tumor to spleen ratio, for instance, for neuroendocrine tumors might be possible. And what about guidelines? I know that the E&M guidelines have been updated, but they're still using the same references here. But this is the E&M guideline from 2010 saying that monitoring response to therapy has been proposed, but still needs to be assessed. And in the updated guidelines from 2017, they say that it basically works despite having any new references here. And the same, of course, applies for neuroendocrine tumors using SSTR PET. It can be used to predict and evaluate response to PRRT, but we don't have any valid hard cutoff criteria to implement. And the same has been told back in 2017 for PSMA, where gallium PSMA PET has not yet been validated for response assessment back then. But recently, as I said, with this publication from Stefano Fanti and the A&M Oncology Group, you see a consensus statement on PET-CT response assessment. And now what I'm doing is something that's actually forbidden if you're having a talk is to include as lot of text as possible, but all of these recommendations are highly important. So considering the first recommendation, it says that in patients, PSMA PET-CT can be used for response assessment after any local or systemic therapy. So we have to use it, we have to incorporate it into patient management. If you go further, once you started a systemic therapy, follow-up PSMA PET-CT should not be performed earlier than 3 months after the initiation of the therapy because it would be too early. And of course, it should not be performed in routine management of patients if it's not likely to have an impact on patient management itself. And this is highly important now in polymetastatic disease. An increase of uptake of tumor volume higher than 30% is indicated for progressive disease. And this is the first time we incorporate tumor volumes, molecular tumor volumes, metabolic tumor volumes into our response assessment with recommendations with specific cutoffs here. And this also says that 2 or 3 new lesions should not be graded as progressive disease if the total tumor volume does not increase higher than 30%. And this is important. So the patient we had in the beginning with decrease of all larger tumor sites, but 2 small new lesions is a responder. That's not progressive disease. And we have specific cutoffs for complete response assessment, stable disease, and partial response evaluation using these recommended cutoff values. Of course, the other question is, will this have impact on survival? And this is data from the Vienna work group from Bernhard Gruppmüller, where he assessed response after lutetium PSMA therapy using PSA levels as a first parameter to differentiate between patients that are responding or not. And he correlated that with total tumor volume and also the mean uptake in this total tumor volume, the ZUF mean in the total tumor volume. And once you consider PSA responders versus non-responders, you see that there is a significant difference in their survival rates. But this is even more apparent when incorporating information from molecular imaging, specifically PSMA PET-CT here. The question, of course, is how do we define the threshold? And this is work that has been done by Lena Unterreiner from our work group, where we wanted to assess which cutoff to use to be able to predict tumor volumes correctly. And we tried different cutoffs, for instance, a fixed threshold of 4.0 as a SUF, or 55% of the max, 60% of the liver, 80% of the parotid gland, 60% of the spleen, different parameters. And we correlated these with the CT volume of lymph node metastasis, because as the morphological size, that was our gold standard here. And we can see that the fixed threshold of 4.0 seems to be the most relevant one that shows the best correlation when correlating it with morphological changes in CT size. And this is that the threshold of 4.0 can be used to quantify PSMA PET positive tumor volume, and it represents an imaging biomarker, which has also been incorporated in the paper I will show you later on. Let's make a switch, because the example that I will show you is based on actinium PSMA. Of course, we will have some talks on that later on as well. So this is sort of a typical, maybe not so typical patient course with metastatic prostate cancer. You have a patient with severe tumor load in the bones, really high PSA levels, and of course all of you have treated such patients. After 2 cycles, the patient shows pretty good response to therapy. PSA decreases to roughly 100, and you see that the tumor volume in general is also decreasing. And after additional 2 cycles, surprisingly, PSA still declines, but if we have a look on the uptake of the tumor lesions, it tends to go up. So this is actually quite interesting, but we still continued therapy because he had PSMA-avid tumor lesions, he had high PSA levels, and he profited from therapy, so we opted for direct salvage therapy after pause of 3 months. And this patient again showed pretty good response afterwards. And after completion of 8 total cycles, we opted for watchful waiting in this patient, and he showed progressive disease again. And in that situation, lutetium PSMA did not induce any therapy response anymore. So this is the time where we at the LMU tend to switch to actinium PSMA. We would rather wait if lutetium provides successful therapy to continue as long as possible, as long as you're not hurting the patient regarding hematotoxicity, renal toxicity, and then we would opt for actinium PSMA, just to the toxicity of the salivary glands. And of course, it's important. So these are patients that have been treated heavily, they have received chemotherapy, they have received lutetium prior, and you can still induce therapy response when using actinium PSMA. And a lot of groups have published their data on the value of actinium PSMA targeted alpha therapy. So in this recent publication, I'm actually the replacement to hold this talk here, because Lena actually, as the first author of this paper, wanted to attend. She could not, and then Markus was asked, Markus Unterreiner, and you can see that they both share the same names. That's not because they're brother and sister, it's because they're married, and they're on their honeymoon right now. So this is why I'm here. Nonetheless, it's my pleasure to present this data and the value of a proper software solution to be able to quantify tumors easily. And this is what we have done here. So we have actinium PSMA patients. That's only a preliminary data with 7 patients with follow-up after the start of actinium PSMA-I&T. And you can see that there is a PSA response in these patients, and it's significant. And there's also significant reduction of the total tumor volume here. If you were to correlate these parameters, you see that there is no significant correlation, which indicates that PSMA-based total tumor volume quantification is an independent biomarker for response assessment, independent of PSA response to the therapy. And this is an example of these, or images of these 7 patients. And this is even more interesting. What we used here was the affinity tool provided by Hermes Medical Solutions, and you can easily, really rather easily, it doesn't take longer than 15 minutes per patient, I would say, or 5 minutes in some cases, to delineate all relevant tumor lesions and to be able to quantify the total tumor volume and also uptake within this total tumor volume to to determine whether a patient is profiting from therapy or not. And this is one of the main approaches for effective and efficient tumor volume delineation is, of course, response assessment. And targeted therapies such as lutetium PSMA, actinium PSMA are the main basic idea behind these evaluations. But of course, there are other relevant approaches which might be important when considering tumor volumes. And this is, of course, a tumor sink effect. This is data from André Gaffita, Technical University Munich / UCLA, where they wanted to prove whether for prostate cancer the sink effect is valid or not. A sink effect meaning that once you have a patient with high tumor load, you will have decreased uptake in healthy tissues such as the salivary glands, the kidneys, the liver. And if you have a patient with low tumor volume, it's rather the opposite way around, so higher uptake in healthy tissue. And this has been proven to be successful, and the first thing you have to be able to do that is a proper software to be able to quantify the tumor volume here. They did not use Hermes, they used, I think PSMA Quant is the tool's name, and I have heard that it can be painstaking sometimes, so I think having a solution that works within a couple of minutes is the main key here to be able to quantify tumor volumes in all patients. And if I were to say to you that I did that in clinical routine the last years, I would lie. I'm not doing it in clinical routine. Nobody's assessing the whole tumor volume within reporting for PSMA. Once you have the time, you can do that, but it's rather a scientific purpose. But with software solutions enabling this within a couple of minutes by just point and click, this can be incorporated into clinical routine and reporting. The tumor sink effect will have severe impact on how we treat patients, actually. So still currently, I know that the data is new and we have an approved therapy option or soon to be approved therapy option here, and we are using fixed doses here. But you have a patient example, again, patient with very high tumor load, PSA 450, severe bone metastasis, and this patient has been treated with 2 cycles of lutetium PSMA, and we can see fairly good response to the therapy. And the patient has been treated with additional 2 cycles of therapy, and he, again, shows very good response to the therapy. But speaking of the tumor sink effect, it might be important, or maybe we should think about starting with higher doses up front. Why not give 10, 15, 20 gigabecquerel at the first cycle, when the mainly tumor lesions are the regions where the uptake will be seen of PSMA compounds and not the other way around. Of course, you will have to think about toxicity here as well, but it might be important to adjust therapy even more patient-tailored. So fixed doses are, in my opinion, not patient-tailored medicine. And another aspect where efficient tumor volume quantification can come in handy is, for instance, this scenario. We haven't published it yet, but we have a couple of patients that had severe bone metastasis of PSMA avid tumor lesions and decreased hematopoietic functional reserve. So patients actually have been killed if we go for hematotoxic therapies in these cases, including radioligand therapy. What we did here was to perform an antigranulocyte scan of these patients to be able to see the active bone marrow and whether there's displacement of tumor lesions and active bone marrow. And once you can include a software solution that will clearly show you where the tumor starts and where the active bone marrow begins, or where the tumor stops and the active bone marrow begins, you can see that this patient will profit from therapy because you will not irradiate his active bone marrow, or it's not in close proximity to the most avid tumor lesions. And this patient has been treated, and his hematofunctional reserve has even recovered after the therapy, which has been proven by other groups as well. So I think there's plenty of areas where efficient tumor volume quantification will be of high purpose for theranostics in PSMA and prostate cancer patients. And within the next couple of minutes, Philipp and his team will show you some videos of how the affinity viewer works. And with that, I want to give over to Philipp again. Thank you very much.
Yes, sir.
Hi.
First of all, thank you for this very nice lecture, and I think you made some really, really important points which are until today not really in the mind, especially of the urologist, right? you were very kind saying it's an additional biomarker, but you should have said it's a really important biomarker, not PSMA, because we are not treating Gleason 6 or 7A or so, but we are treating the undifferentiated Gleason 8, 9, 10. And it's still not in the head of the urologists, you know, that PSA is not playing, I would say, is not playing any role in Gleason 10. You know, and I have seen patients with, you know, a PSA level of 0.01 and disseminated bone metastasis, right? So they say, oh, that can't be, that could be another cancer or something. So this is a very, very important message you made here. You know, PSMA is a really decisive, I would say, only biomarker in advanced prostate cancer. And we can take the PSA course like a GPS system, right? Saying you are driving north or you are driving direction of Munich or Vienna, right? We can take the PSA as a GPS. But the total amount of PSA is not at all important. So many people still think, oh, this guy has only a PSA level of 1.5 or 2. He can't have a lot of disease. This is completely wrong, as you have convincingly shown, right? And that's why I think it is so important to do this quantification, right? And to make and base your decision on the quantification of the PSMA, not of PSA, right? I would say forget about PSA. It's only important, as you have shown, as a GPS, because if you would have based your decision on the PSA in the one case you have shown, you would have thought, oh, very nice response, it's 90% PSA reduction, super, right? We should stop therapy, but you should stop therapy if you still have PSMA-heavy disease. This is a really, really important message you made this morning. Thank you.
Thanks. Any other questions?
No, just a comment. I think one other very important aspect of the talk was really that we should come to individualized dosing, not only in terms of activity, and I think the point is very valid, maybe not to go in with 6 times equal doses, but maybe the first cut is the deepest with a very high starting dose. So that's one aspect, and the other aspect, very nicely exemplified in the salivary gland uptake, is the sink effect. So we may really, in the future, and as we use increasingly planning modalities for these treatments, adapt actually also the mass dose of the substance given to the tumor, to the baseline tumor volume, in order really to have a optimized coverage of tumor. And I think this is completely in contradiction to what the pharmaceutical industry wants, one fits all. But we are in times of molecular radiotherapy, we should really get acquainted to have it individualized, or to consider our individual patient, individual tumor loss, individual receptor expression in order to maximize the uptake. Thanks.
All right, we can go back to Philipp.
Thank you very much.
You have about 15 minutes.
50 minutes, okay, perfect. Thank you very much for the great summary of the research. It was very interesting to listen to you, Harun. Our software Hermia, I have to go back a bit. Our software Hermia is the basis of these impressive images you saw in the talk. However, the images are only a first step in a series of diverse possibilities to now further characterize this volume. In the following, I will show you by video how you can determine the TTV with our software and how you can define and track certain lesions. So now the video 1 should be played. It is not. So in this video, you will see Annika Brunegraf, one of our application specialists. Perhaps you can hear her in the background. how you can use our tools. And first, she will define a threshold, which helps to narrow down the TTV. Okay. Can you please reduce the volume?
Ein Volumen, das Ihnen bereits als Preview.
Thanks. So now you can see that the entire tumor volume is flashing on the right side. And now you can confirm this by just clicking in. You can, of course, change the SUV value for the threshold. You can do whatever you want. It's really easy. Okay. So now she's confirming the volume by clicking in. And it stops flashing, and you see in the statistic toolboxes the values of this volume. I will come to that point. And since there are still physiological accumulations in the entire volume, for example, the kidneys, as you mentioned, these must still be excluded. And this can be done very easily by simply selecting them and excluding them. And she's now showing it to you how she's doing that by just clicking in and excluding it. Simply easy. So and once you have excluded all areas you do not want to have in, you also have your total tumor volume. And I think that's a really fast method to do this. I will now, okay, what you can see here that's very interesting is that there is a small lesion attached to the bladder, and you can just divide them by clicking in, and it's automatically divided. So that's really, really easy. Okay. I will now jump to the next video. Video 2, please. And video 2 is just an overview how it can look like. You can define areas, different areas, as much as you want. That's quite easy and really, really nice to do. Okay, and now please play video 3. In the third video, you will see how to use our lesion tracking tool and what it is capable of. You see now 4 time points of the same patient. You can load in as many time points as you want. It doesn't matter. And again, you define the total volume using a threshold, for example, and can now actively define an area or or lesion by marking it. So she's now changing the threshold, and in the next step she will just click in and define the lesion she wants to be tracked. So, and you couldn't do that for every time point, by just clicking in. And what you will now see is that there's a small lesion attached, and you can divide this marked area into sub-areas. And to do this, we have a function which is called blob splitter. And with this blob splitter, you just have to click in, and it will automatically divide the lesions. And in the lower area, you will see now all the statistics in graphical or tabular form, and you can switch between the values, for example, as the mean, the max, or the TTV. And it's quite nice to track the lesions. And of course, you can mark as many lesions as you want. So as many time points, as many lesions, they are not limited. Okay, while playing this in the background, I hope you enjoyed Dr. Ilhan's lecture as well as my explanations about our software. And I will be very happy to answer any questions you may have after this session. If we were able to arouse your interest, and I'm sure we did, please feel free to make a demo appointment or to contact me. And I would like to thank you all for your attention and hope you enjoy the rest of the presentations. Thank you very much.
We still have about 10 questions, 10 minutes if there are questions. Or comment.
What you've seen here with that video is actually what I do in clinical routine now. I don't know, most of you, if you're measuring your tumor lesions yourself when reporting, or whether you have a technician or med student or intern, whatever, to do it for you. But as Philipp already said, I just switched to the private practice as well recently, despite being at the LMU still as a scientific lecturer. And I have to write my reports on my own. So it takes quite some time, you know it, if you have a lot of tumor lesions and you want to provide for the clinician or for another purpose, all of the detailed information, whether it's an increasing uptake, not only for PSMA, but also for FDG, whatever. So what I do with using Affinity is it takes a couple of minutes to start up front. I try to quantify all of my tumor lesions, and once I have my values on hand, they will be displayed in the MIP as well. And you can scroll through the image just using your measure to measure the size of the lesion, and it's coming in so handy because you can use one hand for your report, and the other one's just for measuring and scrolling through, and it's much more time-sparing than it was with the hybrid 3D system, also by Hermes, and which we used before. So it's relatively easy to include all of these new and valid data of total tumor volume delineation, uptake within this total tumor volume, into clinical routine, into reports, because this is what we have to do if you want to go forward with this message, that this is of value. We have to use it in clinical routine as well, not only in papers, because this is what will make the difference, to convince the clinicians, not only urologists, but oncologists, that these new measures are important to be incorporated into clinical routine. Just a comment.